What's up, everyone? So, we are working denials today. Thank you so much for those that replied last week on my denials video, letting me know that these videos are helpful and encourages me to keep on recording me doing denials and talking them through. I'm going to try my best to provide more information when I'm doing the denials. Sometimes when I'm working the denials, I'm thinking things through and I don't necessarily verbalize them, what I'm doing. And so when I go and rewatch the videos and edit it, I'll be like, oh, I should have, said this and that or whatever. So I'm going to try my best, but keep asking questions if something isn't clear. And yeah, we're going to get started. So I don't have that many denials this week, which is a good thing. Hopefully I don't next week don't get inundated with a bunch of them. But I'm going to these first few denials will be random. There's just some things that the biller sent me through email. We get denials in various ways. Most of our denials come on a spreadsheet, and then some denials that's like hitting timely really quickly, or they feel like we aren't answering fast enough, they'll send it to us via email, and then try to CC our managers on that so that we can move a little bit quicker. But with month end being this during this course of my denials, I just kind of put the denials off until I got done with month end. So if you are interested in watching me work these denials, then I invite you to keep watching. So this denial is basically saying that Blue Cross Blue Shield is not accepting a level 5 visit for telehealth. And they want to know if this can be billed on level instead of time. So I'm going to go ahead and take a look. So we do have a company policy that our behavioral health providers know that they should not bill out a level 5. We need to re-level those because of this Blue Cross Blue Shield issue. So I'm just going to go ahead and update the CPT code and get that claim out the door. All right, so I'm done with the ones that I have being received through my email. So I'm going to go to my spreadsheet. The first specialty that we'll be looking at is behavior health. And this first, I only have 3, it looks like, that I need to address this week. And the first one says the ICD-10 code is unspecified. Can we review to see if there is a more specified code? So, as you probably know, some payers are really honing in on unspecified codes. They don't like us reporting unspecified codes. They want us to get as specified as possible. Hence why we have ICD-10, because it's really, really specified. So I am going to look to see if there is another specified code, and if not, there's other codes on here that I already see that I should have sequenced first. But let me look at the reason for visit and we'll just go from there. I honestly don't know why I let this claim go out this way. I use R41.9 as the primary code. And that's not a code that I know that, that should be on here. So I'm going to delete that code. Per the documentation, this code is not even on this documentation. This must have just been something that was oh, I see where I picked it up from. Okay, never mind. It is in the documentation. It's just in a different place than where I usually look at. So I'll add it back and just sequence it last because it's not the primary reason for visit anyway. All right, so we got that one out the way. Just let me go ahead and make my notes. So this next one is saying that CPT code 96156 was submitted with a primary DX code F41.1 and is not eligible for reimbursement. So what I am learning is that with CPT code 96156, they do not want us to build out the F codes because that is for the mental health status. And the 96156 is not treating the mental health, it's treating the other conditions surrounding the mental health, be surrounding the test for that. Let me just pull up the verbiage for that so I can explain it a little bit better. Okay, so CPT code 96156 is for the health behavior assessment or reassessment. So it's a health focused clinical interview, behavior observations, or clinical decision making. The health risk assessment identifies the psychological, behavior, emotional, cognitive, and relevant social factors that can prevent, treat, or manage physical health problems. So, this code, even though it is given in the behavioral health clinic, they're not treating uh, the mental health or behavior health diagnosis for this patient. They're actually looking more at the physical health, problems of the patient. Maybe asthma. I've seen some quadriplegic heart issues, a lot of diabetes patients. So it just depends on this patient physical diagnosis and that they need some kind of health behavior assessment regarding, and it's usually newly diagnosed things. So like if you've been recently diagnosed with cancer, that's a big one. I will see, this assessment done on patients to help them like understand and deal and cope with this new diagnosis that they've received, or if the diagnosis has like advanced or something like that. So that's what they're basically helping them to cope with this with that. So this particular patient, they're dealing with stroke-like symptoms, some kind of like weakness in their face muscles. So they're probably trying to figure out how to cope with that. So that's what actually we should be billing out for this particular code and not the mental health diagnosis. So that's something that I am trying to make sure that I catch when I see this particular code. I actually am about to document this on my cheat sheet so that it'll remind me until I get used to it that CPT code 96156 needs a medical diagnosis and not a behavioral health diagnosis. And the reason why I report the mental health diagnosis is because that's what the provider picked. But I don't even know if the provider is aware that these diagnoses is falling on the claim. So I'm just going to, provide a little education in our next meeting just to let them know that this is a trend that I have been seeing with my denials. And so that we both can kind of, be on the same page when they are documenting, they can at least help me to pick out the correct diagnosis code if it's not falling on the claim correctly. Because I can just go in and adjust the code, the DX codes, as long as it's documented in the clinical notes and supported. So I just updated those DX codes, and I am go ahead and correcting that. Okay, so my last one is saying that I used a DX that has a codes first guideline. So F0781. Yep, it's other personality and behavior disorder due to a known physiological condition, and that is a code's first. A good hint for new coders that you are using a code that has a code's first rule is if it says due to other known physiological condition. So that lets you know that this condition that you are, reporting is brought on by another condition. So you need to code that other condition first to basically tell the story that there was something else that caused this condition. So let me take a look at that and let's see. I probably just didn't sequence it right. This patient had a concussion, and the concussion was probably due to, most cases, it's like a sport that they played and, received a concussion. So they probably had a fall or a tackle or something like that, and I didn't pick that up. So let's see if it's documented here. So it was a fall. So I'm going to code this as an unspecified head injury due to a fall. Because it's an injury code, it's nice to have why it was coded, but this is going to be a sequela, which is an after effect. The post concussion was the after effect of the fall. The post concussion syndrome was the after effect or the late effect to the fall. So they're treating the late effect. The fall happened months ago. Now the patient is suffering from post concussional syndrome, but it was due to the fall that happened months ago. So this is a code. If you remember your coding guidelines, your initial visit is usually coded with an A at the end, your 7th character as an A. You have a D at your 7th character for your active treatment, your continuing treatment, and you have your S as the 7th character for your late effect. So in this instance, this will be an instance that we will use the S for the 7th character for the late effect, because the patient had this head injury that happened a while ago, and they came back in because now they're suffering from residual effects of that head injury, and it's due to a fall. Per coding guidelines and payer rules, we don't necessarily have to report the activity code, for this instance. But if it's known, if it's documented in the clinical note, then it's best practice to also document that, it was for a fall. But you definitely have to document the fall for when you are reporting the A, or the initial visit, because they need to know what happened, and it's like for statistical purposes, but also, to make the medical record complete for the patient, because you're telling their story basically. And it doesn't say if the person was pushed or um how it doesn't tell us how the patient fell in the record, but it does say. So I'm going to just pick unspecified fall and also code that with the 7 character S. And that tells the complete story that this was a late effect fall, a late effect head injury that received that's being treated today for post concussional syndrome due to the fall, and the fall and the injury code both have the 7th character S. So if you guys want more information on like what I'm talking about, if you don't understand the 7th character S, I'll go ahead and link a video that I did about the first part of the coding guidelines, and it will explain the 7th character a little bit more in detail for you. But yeah, we have to report that the late effect code. So all right, so this is cool. So I am done with behavioral health, and now we are going to move on to urology. All right, it looks like I have 4 denials this week for urology. Let's see some older ones that it says I didn't address. So let's take a look and see why I skipped those. All right, so it says that the services are not covered in global period of another service. CPT code 53440 and 50845 was billed out on December, whatever, and it has a 90-day global period. Please review. CPT code 99211 is being denied. So this patient came in for an inpatient stay, and they want to know basically if this visit was related. Well, the payer is thinking that this visit was related to a surgery that the patient had prior to this date of service. And so what I have to do is go ahead and check to see if this visit was unrelated. And if it was, then I will go in and append a modifier to let them know that if it has something to do with, maybe, a complication or a follow-up visit. But if it's inpatient, I would think it would be more of a complication. Then I'll go ahead and just like let it fall into the global. So let's see. Patient came in. All right, so I went ahead and made that a post-op visit. So this next one is basically saying that there was a visit in the global again. So CPT code 52290 was billed out in the global of 50780. So 52290 is for a cystourethroscopy with urotal myotomy, unilateral or bilateral. And then they're saying that it was billed out during a global of 50780, which is a uroneocystostomy, anastomosis, single ureter to the bladder. Probably was one of those things that the provider said that they performed both during the session and one got paid. It may be an unbundling. Let me see. Let me just see. Okay, so what I found out for this code is that 50780 was done first, and then just shy of the 90-day global period, the patient came in and had the 52290 done. So this is going to cause us to have to look at the medical note to kind of like piece together what happened with this patient. And then we can see which code would be the best. So since the first visit happened in December, I'll go back into the note and try to go into December and just like try to pull up all the urology visits to see if I can figure it out. What would be best is if the doctor or the physician or the provider would document that, yeah, they had to go back in because there was a complication or because the patient something else happened with the patient that caused them to have to have another return visit to the operating room. So I figured out that the patient came back in for a stent removal. All right, so I decided that I'm going to use modifier 58 because after looking in the medical record, it shows that this particular procedure was actually related to the initial procedure when I was reading all the notes from in between the two dates of service. So the patient came in for whatever procedure, got some stents placed, and this procedure, they removed the stents. So those two are related because they placed the stents, they removed the stents, and so they are a related procedure. Um, and in one of the notes, I read that the patient was aware that this may have to be taking place, but the decision wasn't final as to when. So, in my opinion, that is staged. That means that they were anticipating that they were going to have to do this service to the patient anyway during the post op period. So modifier 58 says stage or related procedure or service by the same physician or other qualified healthcare professional during the post-operative period. It may be necessary to indicate that a performance of a procedure or service during the post-operative period was A, planned or anticipated, which means staged, B, more extensive than the original procedure, or C, for therapy following a surgical procedure. This circumstance may be reported by adding modifier 58 to the stage or related procedure. So that seems like it's the most impactful modifier for this particular denial. So I am going to go ahead and add that modifier to this and just make a note. Okay, so this next one says that the payment was adjusted, the level of service was not supported. Can you please review the notes and confirm that this is supported? If so, let me know in the notes that it was supported. So what's being questioned is CPT code 15740, and that is a flap island pedicle requiring identification and dissection of an anatomically named axle vessel. So let's take a look at this medical note. Okay, so I did find where that CPT code is supported. The patient dissected some tissue dorsally, taking care to preserve the blood supply, which originates from the external pendule. So that lines up with what a flap island pedicle is. It says the skin and subcutaneous tissue containing a neurovascular link is trimmed for use in the island pedicle flap. The extra tissue is removed from the pedicle so that the connection to the donor site is a little more than innervated artery and vein. A defect is covered by the elevation of the flap of skin and subcutaneous tissue from the nearby but not immediately adjacent donor site. The flap involves the anatomically named blood vessel in its creation. Often the tissue is transferred through a tunnel underneath the skin and sutured into the new position. The donor site is closed, and you will report this code. And so it basically says that they make a pedal incision, they tunnel it underneath with the blood vessel, put it to the donor site, suture it in place, and kind of close everything up. Close the donor site up. So basically, they're saying that they dissected the tissue to preserve the blood supply. They show where it originated from. They took that tissue and then they sutured it over the defect that they did. They did a urethroplasty, and then they sutured it in place. And they made sure to close up the donor site. So I'm going to go ahead and get this screenshot and share it to the billers so they can send the medical records over and know what to point out to the payer so that we can get this overturned and get this one paid out. So we are done with denials for this week. I got a comment I wanted to address. Someone has said, please tell everyone to stop using Z codes as the initial diagnosis because that creates denials. And so I thought that was interesting to talk about, and maybe it should be a video. But I wanted to point out, depending on your ICD-10 CM book, I have the Optum ICD-10 expert book. I don't know if it's in any of the other books, but we have in Appendix D, Z codes only as principal first listed diagnosis. So this book actually, hopefully it shows This book actually gives you in Appendix D a list of Z codes that is okay to be listed as the initial diagnosis. These are the only Z codes that the payers may um, accept as initial diagnosis. So take a look in your book to see if you have the Appendix D Z code listed as the initial diagnosis, because that comment is correct. All your other codes will be denied as because you can't list them as the initial diagnosis if there's Z code. It's part of the sequencing rule for your coding guidelines. And I'm trying to see if I can find. If we look at coding guidelines under Section 1, Convention B, General Coding Guidelines, and you have to go all the way to number 19. So, Convention 1, Section B, number 19, it states use of Z codes. And I'll put a screenshot up here for you, but it says Z codes for other reasons for healthcare encounters may be assigned as appropriate to further explain the reason for presenting for healthcare services, including transfers between healthcare facilities, or provide additional relevant information to a patient's encounter. The ICD-10 CM official guidelines for coding and reporting identifies which codes may be assigned as principal or first listed diagnosis only, secondary diagnosis only, or principal first listed or secondary depending on the circumstances. Possible applicable Z codes includes, and then they give you a list of Z codes that it includes. So that may be a little confusing, but essentially Z codes are like more information. Z codes usually aren't like this is why the patient came in. If you look at chapter 21 for Z codes, it states that factors influencing healthcare status and contact with healthcare services. So those codes is just factors that influence the healthcare status of the patient or why the patient is coming in contact with healthcare services. It's not like principal diagnosis. They also tell you here that the chapter specific guidelines from the official guidelines for coding and reporting have been provided to show guidance. Along with these guidelines are coding examples. This is in my book, contained in the shaded boxes that have been developed to help illustrate the coding and or sequencing guidance found in these guidelines. Note, the chapter specific guidelines provide additional information about the use of Z codes for the specific encounters. So, use of Z codes in any healthcare setting. Z codes are for use of any healthcare setting. Z codes may be used as either a first listed principal diagnostic code under certain circumstances or a secondary code, depending on the circumstances of the encounter. Certain Z codes may only be used as first listed codes. So, you have some Z codes that has to be sequenced first. In other words, you have some Z codes that you have to have as principal diagnosis. They can't be secondary diagnosis. They can't be, they have to be listed as first. And those was the list that I showed you in Appendix D. Then you also have some Z codes that gives you the status of the patient, like the patient was homeless or the patient, has like extenuating circumstances in their living conditions. The patient has a do not resuscitate order on file. Your BMI will be reported with a Z code. If you came in contact or you was exposed to something, you may be a genetic carrier. Those are Z codes. So instances like those, you may not necessarily need to put those as the initial code, because that's not really what you came into the clinic for, but it is helping to tell the story of why you came into the clinic. So, for example, of a Z code that may be listed first, may be like you came in for chemotherapy. So, accounting for chemotherapy is a reason for visit. You know, you probably only came in for chemotherapy, so you would list that Z code first, and then you will list the specific cancer that's being treated. So take a look in your book and see if chapter 21 has more information for you. It's a lot of information in this chapter 21 of my book to help direct you with how to, properly code Z codes. And some Z codes have to be listed the first diagnosis on the claim, and there are certain Z codes that just tell the story of the patient. So yeah, I had someone comment that, and so I was like, you know what, that's a good thing to talk about, because that actually did come up in our last chapter meeting. Some people were, we had a denials meeting for our chapter meeting, proper way to report denials and how to prevent them. And one of our members stated that they report Z codes. They only report Z codes, and only one payer doesn't like the Z codes, and now they don't know what to do because all they've been doing was reporting Z codes. And it was talked about and debated that Z codes shouldn't be used as principal diagnosis anyway. So, whatever. But sometimes you can get away with reporting certain codes with payers that, they will let slide until they do like an audit, and then they happen to pick up that you've been using, you haven't been sequencing codes right, or haven't been reporting the codes in the proper context. Then that will cause them to go back and want to audit other records. And if they see a pattern of that, then they'll start doing recoupments and all that stuff. So just make sure that you understand the sequencing rules with all the codes, but in regards to Z codes. So anyway, they are mowing the lawn out there and they're about to come back. So I'm about to go ahead and end this video. I hope everything that we've talked about today helps. If you have any comments or any questions, or just want to give any words of encouragement, please do so in the comments. And yeah, until the next video, I'll talk to you soon.